Welcome to Pulse&Pressors, where critical care gets crystal clear. Rocuronium is the dominant non-depolarizing paralytic in modern airway management. Its unique pharmacology, dosing strategy, receptor kinetics, and reversal profile make it the most versatile neuromuscular blocker in emergency medicine, ICU practice, and operative airway control. This masterclass highlights the expert-level details needed to use the drug with precision. Rocuronium works by competitively blocking nicotinic acetylcholine receptors at the neuromuscular junction. Unlike succinylcholine, it does not depolarize the muscle membrane. Instead, it prevents activation entirely. Paralysis develops as receptor occupancy rises to a critical threshold. The RSI dose of rocuronium is intentionally far higher than the ED95. Fast onset requires overwhelming the neuromuscular junction so that nearly every receptor is blocked instantly. This explains why 1.2 milligrams per kilogram mimics succinylcholine's onset, while lower doses do not. The trade-off is significantly prolonged paralysis. High-dose rocuronium produces reliable paralysis in under 1 minute. However, the same large dose extends duration into the 45 to 90-minute range. Low cardiac output, hypothermia, and acidosis prolong onset and duration further. Critical considerations in shock, trauma, and post-arrest patients. Rocuronium undergoes hepatic uptake with biliary excretion. It is not heavily metabolized, but impaired hepatic blood flow, common in shock, sepsis, and high-dose vasopressors, dramatically prolongs presence at the neuromuscular junction. This is why ROC behaves unpredictably in ICU patients. The elimination half-life of rocuronium in healthy adults is typically 60 to 120 minutes, placing it in the intermediate-acting category. However, this half-life can be significantly extended, even up to many hours, in critically ill patients due to impaired hepatic and renal clearance. Rocuronium is the modern RSI workhorse. It provides excellent intubating conditions without the potassium shift, MH trigger risk, or prolonged depolarization issues associated with succinylcholine. High-dose ROC is safer in burns, crush injuries, neuromuscular disorders, and severe hyperkalemia. When given at RSI dose, rocuronium reaches an onset comparable to succinylcholine while avoiding dangerous potassium shifts or MH triggering. The primary trade-off is prolonged paralysis, making ROC the safer but longer-lasting choice in most ICU and ED scenarios. Precise dosing determines success. RSI requires high-dose ROC for rapid onset. Smaller doses are appropriate for maintenance paralysis, but should never be used during RSI because onset becomes dangerously slow and unpredictable. Critical care pharmacodynamics strongly affect rocuronium. Hypothermia and acidosis slow drug clearance and prolong paralysis, while aminoglycosides increase neuromuscular blockade. Conversely, chronic anticonvulsant therapy increases rocuronium requirement due to receptor upregulation. Rocuronium is safer than succinylcholine in nearly every complex clinical scenario, except situations requiring extremely short paralysis. It is the paralytic of choice in head injury, hyperkalemia, burns after 24 hours, and neuromuscular disorders, all of which carry risk of fatal depolarization with succinylcholine. Sugammadex changed airway management by allowing instant reversal of rocuronium, even at large doses. However, after reversal, residual Sugammadex can capture newly administered rocuronium, causing sudden and profound paralysis. Pitfalls stem from pharmacokinetic variability. Underdosing leads to dangerously slow onset. Critical illness prolongs effect. Paralysis without deep sedation remains a catastrophic mistake. Rocuronium also accumulates during prolonged infusions, leading to unpredictable recovery times. These real-world scenarios reveal rocuronium's strengths: safety in metabolic derangements, predictable onset, and suitability for prolonged ICU management. It is the paralytic of choice when avoiding succinylcholine is essential or when long paralysis is desired for controlled ventilation. Rocuronium's versatility makes it the top paralytic across critical care settings. Its pharmacology rewards clinicians who understand receptor occupancy, dosing strategy, and reversal interactions. Mastery comes from anticipating altered physiology in shock, organ failure, hypothermia, and post-arrest states. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.